discuss the fetal growth restriction protocol that we have for the fetal medicine unit. So I'm going to first of all start by giving out definitions and then highlight the disease burden and then discuss some of the risk factors, and then finally go on to how we diagnose or identify fetal growth restriction and then management using the fetal medicine unit protocol. Now, by definition, fetal growth restriction, we say a fetus is growth restricted if they're failing to achieve their genetically predetermined growth potential. This is a common and complex obstetric problem which affects about 10 to 15% of all pregnancies, but different studies vary, and some have said 5 to 10%, some 10 to 15%. So on average, it affects about 10% of all pregnancies. And what we've realized that fetuses which growth restricted are at an increased risk of perinatal morbidity and mortality. If they manage to survive the peripartum period, then they also have long-term complications. These long-term complications may be seen in childhood, where they're at high risk of cerebral palsy, growth delay, short stature, and neurodevelopmental impairment. And then in adulthood, later on, you think that they'll be rid of all this problem, but now they are also at high risk of what we call non-communicable diseases, which are hypertension, metabolic syndrome, type 2 diabetes mellitus, coronary heart disease, stroke, and obesity. So it is of paramount importance that we diagnose fetal growth restriction if we are to avoid some of the risks that are involved with it, that is the perinatal morbidity and mortality, and also possibly avoid future handicap. So that's why it's important when we are scanning that we realize if a fetus is growth restricted. Having said that, I'll also define what small for gestational age is, as this is sometimes used in place of fetal growth restriction, but they are not necessarily the same. Small for gestational age is when a fetus is seen to weigh less than the 10th percentile of the gestational age. So at any given time when we scan a patient, if that fetus is less than the 10th percentile for the gestational age, then we say that this fetus is small for gestational age. In general, these small for gestational age fetuses are also at higher risk of perinatal morbidity and mortality. But the risk has been recognized to be highest when the estimated fetal weight is less than the 3rd centile. And because of that, in some literature, it says that if the estimated fetal weight is less than the 3rd centile, then automatically you should say that this fetus is growth restricted. Having said that, the majority of the fetuses who have fetal growth restriction are actually within the category. They are also small for gestational age. So the diagnosis of a small for gestational age is pivotal in the diagnosis of fetal growth restriction. That is why we flag them when we see them in the fetal medicine unit, these fetuses who are small for gestational age, because the majority of them are going to be actually growth restricted. And then within the group of the fetuses, those ones who are small for gestational age, there are also some who are actually normal. That is, they are not at increased risk of poor perinatal outcomes. These are constitutionally small, but we only make this diagnosis retrospectively to say that this baby is actually constitutionally small after following up this baby. Having said that, also some fetuses may not be small for gestational age, but may still be growth restricted. What do I mean by this? If we look at this, sorry, I'm just going to get a pointer. If we look at the diagram, which is in front of us, what it highlights, the blue region is for appropriate, for those with an appropriate gestational, who are grown appropriately for the gestational age. But what you see is that there's this line here, it shows a small for gestational age babe, but who's consistently moving along their percentile. But this one, the one which is bold and continuous, small, shows also a small for gestational age baby, but who also is growth restricted in that they are losing their trajectory and becoming smaller and smaller. They're not following their trajectory that they were on before. Whereas this one if we were to follow up this baby, we'll say that this baby is appropriate for gestational age, but later on, as you realize, it also falls off its trajectory. So although it's within the appropriate for gestational age category, it's actually growth restricted because it's falling off its trajectory. And then the other thing that we also realized that, as I tried to highlight, those who are small for gestational age, that is less than the 10th centile, they may be normal small, who I said are constitutionally small, but within that also there may be others who are abnormally small. By abnormal small, I mean those who are pathologically small. When the fetus has, for example, some chromosomal abnormalities or genetic abnormalities, we say that they are pathologically small. And my talk today is not going to concern those who are abnormally small, but it's going to be on those who are starving small. So for those who are starving small, some of them may have this fetal growth restriction as early as less than 32 weeks, and others will have it later than 32 weeks, which is the majority actually of the babies who are growth restricted. Now, in terms of the risk factors for fetal growth restriction, any women with chronic hypertension, that is predating the pregnancy, will be at high risk for fetal growth restriction. Then with chronic anemia, in our setup, we see those with sickle cell anemia. They may have chronic anemia, and this may cause fetal growth restriction. And then with severe cardiopulmonary diseases also may lead to fetal growth restriction. Those with chronic diabetes predating the pregnancy, because of the accompanying vasculopathy, may also have fetal growth restriction. Those with chronic renal disease, the mothers. But also there are some obstetric factors which make the women, the babies also at high risk of fetal growth restriction. In this case, if the mother at that particular time, when she comes to you for scanning, has severe preeclampsia, then you should suspect that the baby also may be growth restricted. And then, or if she has a history that from her previous pregnancies, she actually had severe preeclampsia, especially if it led to a preterm delivery, less than 34 weeks, or if it led to intrauterine demise, then in that case, you should also suspect that the current pregnancy may be complicated by a fetal growth restriction. Also, if the woman is screened, if she comes early enough at the 11 to 14 week scan when we were able to screen her, and also she was found to be screen positive, in this case also we should suspect that the baby might end up getting fetal growth restriction, or even at the 20-22 week scan. Also, if they have an previous unexplained intrauterine fetal demise or previous unexplained recurrent pregnancy losses, then we may also suspect that they may the babies might be growth restricted. And then in addition, if they also take part in some social behaviors which may be detrimental to the growth of the baby, like smoking, or if they use illicit drugs, or if they drink heavily, then this may also lead to fetal growth restriction. So these women, when they come to us for scanning, we should be highly alert and scan their when we are scanning their babies, as these babies may actually have fetal growth restriction. Now, in terms of diagnosing the fetuses with fetal growth restriction, or how we identify them, firstly, I've said that we need to risk profile them, and these women who are at risk be alert that their babies might have fetal growth restriction. We also need accurate dating of the pregnancy. Now, for us to be say a baby is small for gestational age, we must know the appropriate gestational age where they are. So, unfortunately, in our setup, this ends up being a problem because women present quite late to us in 3rd trimester or 2nd trimester. If possible, we want to scan them at the 11 to 14 week scan and establish the proper dates. But if they come later on, we don't give up. We normally use our head circumference and get the best date that we can, and then use it for follow-up to be able to determine whether the baby is fetal, it's growth restricted or not. Then also now we also do ultrasound scan for fetal growth using our normal parameters. If at any given time, as I said, the estimated fetal weight is less than 3rd centile for that gestational age, then we may say that this baby has fetal growth restriction. But in general, if the fetus is less than the 10th centile, the next step that we should do is to do the Dopplers, the Doppler velocimetry, and then also put the baby on surveillance for serial growth scans. In terms of the serial growth scans, This will help in assessment of deviation of growth of the fetus from its normal growth trajectory on the growth velocity charts, which I showed you earlier, and this will also help us to establish the diagnosis of fetal growth restriction. But besides that, when we are looking at the Doppler velocimetry, what basically we mean by this is that we are interrogating the blood vessels. This may be maternal, uteral, placental, or fetal circulations using ultrasound scan, and this helps us to see the direction of blood flow and also to characterize the blood flow. Now, Doppler velocimetry helps us in 3 ways in terms of fetal growth restriction. Firstly, is the screening, and then later on it helps us to diagnose fetal growth restriction, and then later on it helps us in surveillance and management of the pregnancies complicated by fetal growth restriction. When I say screening, what do I mean? I think I heard Dr. Verenga mentioning that if patients present early enough at the 11-14 week scan, we can actually do a screen using the uterine artery, the maternal uterine artery Dopplers, to see those who are at high risk of getting fetal growth restriction. This is very important. In some studies, they've shown that the first trimester scan for uterine artery Dopplers can apparently predict 81% of women with early onset preeclampsia, 45% with late onset preeclampsia, and even up to 50% with gestational hypertension, with a false positive rate of 10%. So what does that mean for us? What does this translate to? If we get women who are at high risk of getting these complications of pregnancy, there is also high risk of getting fetal growth restriction. Hence, we can actually begin them on aspirin timeously, because we know that we have to begin it early in the first trimester before the 16th week for them to get the full benefit of the aspirin, of the 150 milligrams of aspirin. Also, screening can also still be done later for the women who present to us late. We don't have to say, no, you didn't come at the 11-14 week, we're not going to screen. We'll still screen them at the 19-23 week scan. Now, this helps in 2 ways. We'll also be able to identify women who are going to have late onset fetal growth restriction. So we may keep them under surveillance once their Dopplers show that they have high PI. But on the other hand as well, if a woman presents and she has a small baby, and we've screened and we've scanned her and we've confirmed that there are no fetal abnormalities, we may be able to say there is a placental cause for the fetal growth restriction based on the fact that we see that the uterine artery Dopplers are abnormal. In terms of the technique, how we do the uterine artery Doppler, we can do it transabdominally or we can do it transvaginally. We've been doing it mainly transabdominally at the fetal medicine unit. We don't have many first trimester patients. So transabdominally, the probe is placed longitudinally in the lower lateral quadrant of the abdomen. And then we angle it medially. And then we apply our color flow mapping so that we identify the uterine artery where it crosses the iliac vessels, that is the artery in the vein. So when we see where it's crossing, then we're going to put our sample gate about 1 centimeter downstream from the crossover point. We don't put it at the crossover point, a little bit 1 centimeter downstream from the crossover point. And then we measure the uterine artery Doppler. In terms of diagnosis, the Dopplers, they play a central role in identifying and also diagnosing fetal growth restriction, because they help us, they allow us to identify uteroplacental insufficiency. As you can see from the diagram that is above, the first one shows a reduced end diastolic flow. This is peak systolic flow, and then this is end diastolic flow. So this is relatively reduced from the normal one, the end diastolic flow. So if we see that a baby, even though they are appropriate for gestational age, that is their weight is appropriate for gestational age, that they also have Dopplers which are abnormal like this, then we can say that this baby is growth restricted, because obviously because of the placental insufficiency, they cannot gain their optimal genetically predetermined weight. In terms of surveillance, we can also use the umbilical artery for follow-up. Once this baby presents like this, if we follow up in 2 weeks' time, we may find that there's now absent end diastolic flow. And if we continue following up, then we may find that there's now replaced end diastolic flow. So the umbilical arteries are going to help us not only in diagnosis, but also in surveillance and later on management of fetal growth restriction. So in order to sample the umbilical artery Doppler, we need to visualize a cord, the umbilical cord. Once we visualize the umbilical cord, we want it to be free, a free loop of cord. We don't want it to be instead close to the fetal cord insertion or the placental insertion. And then after that, we magnify the area of the cord, and then we switch on our color Doppler, and then we measure. And our gauge should be 2 millimeters as we do that, or smaller. Now, the middle cerebral artery and ductus venosus are also very important as they show the fetus response to hypoxemia. What happens is that when the baby becomes hypoxemic, then there's going to be vasodilation of these blood vessels within the baby's brain. So in terms of how we get the middle cerebral artery, what we need to do is to identify, first of all, the circle of Willis. And to do this, we put the, we need an axial section of the brain, which should show the thalami as well. And this is the third ventricle here in front. And then we identify the circle of Willis. Here you can see part of it going this way. Once we've done that, then we want to identify the proximal middle cerebral artery. And then we're going to put our pulse wave Doppler gates at the proximal third of the middle cerebral artery, close to its origin, but not at the origin, close to its origin at the proximal third. And then the angle between the ultrasound beam and the direction of blood flow should be kept as close as possible to 0%. And then we want to get at least 3 waveforms, but fewer than 10 consecutive waveforms, which are basically the same. Then you record them, and then you can now measure them. So the middle cerebral artery waveform, as you can see here, the diastole is like this, but here it's relatively fuller. So obviously this is a fetal which is complicated by growth restriction, because it is fuller here in the diastolic phase, the velocity there, when you compare to this one. And then also alteration in the ductus venosus waveform, especially the upside or reverse A wave, are caused by progressive dilation of the ductus venosus isthmus in order to increase the blood flow towards the heart in an attempt to compensate for the extreme oxygen deprivation. So in this case, you are seeing the ductus venosus, the nominal Doppler waveform. There is this S, which corresponds to the systolic, to the ventricular systole, and then there's this D, which corresponds to the early diastole, and then there's this A, which which shows the A, the atrial contraction. So it's a triphasic waveform, as you can see. And then in terms of measuring the ductus venosus Dopplers, we can do it in 2 ways. Either in the transverse, we can get a transverse section of the fetal abdomen, the one that we normally use when we are measuring the abdominal circumference. Or we can do it longitudinally. As you can see here, this is the ductus venosus. And at this point here, where the hepatic vein turns into a portal sinus, we can see the ductus venosus there. So we can sample it from there. Now, what is important is that we need to recognize that there are 2 forms of fetal growth restriction, which are different in their characteristics. With early onset fetal growth restriction, we say every fetus which has fetal growth restriction at less than 32 weeks, then this is early onset fetal growth restriction. Whereas if this occurs at greater than 32 weeks, then we say this is late onset fetal growth restriction. The main challenge in early fetal growth restriction is that is more of management, not of recognition. We can easily recognize it because the baby is, because the fetus may be very small, so we easily recognize it. And the mother also may have hypertensive disorders of pregnancy. So we may also be able to suspect it. So we easily recognize it. But management is difficult because the babies are very small and they are suffering. And we need to know when we should deliver for a good outcome for both the baby and sometimes also the mother who has severe preeclampsia at that particular point in time. And in terms of prevalence, it tends to be less than the late onset one. For early onset fetal growth restriction, 30%, the prevalence is about 30%. And also in terms of Doppler velocimetry, the spectrum of Doppler alterations are all there for us to see. They involve the umbilical artery, the medial cerebral artery, and the ductus venosus, and we can actually follow up for most of them and see how they are deteriorating before we have to do a delivery. And if we take histology of the placenta, if we send it for histology, what we see that there's signs of poor placental implantation with spiral artery abnormalities and maternal vascular malperfusion. And the perinatal mortality for these babies is high. Whereas with late onset fetal growth restriction, it is more difficult to detect. It is more subtle. And also it occurs in the majority of cases of fetal growth restriction, about 70%, and it's going to occur later on in gestation. It's more than 32 weeks. And what we recognize that the fetus are not necessarily very small. So that's why it's very difficult for us to be able to detect. And in terms of the Doppler, what we normally use is a cerebral blood flow where we see redistribution. And this may be the only abnormality that is there. So this is very important for us to know. And frequently also the mothers don't have hypertensive disorders for us to suspect. And when we take the placenta for histology, the changes there are less specific. So they mainly show also diffusion. And the perinatal mortality in this case is low for these babies. So in terms of diagnosis, I've already said that we need to do to know the risk factors, and then also to scan for the growth, and then later on also to do the Dopplers. So in a nutshell, what we can say, if the abdominal circumference or estimated fetal weight is less than the third centile, then these babies are growth restricted. This is for early onset fetal growth restriction. Or if at any given time the umbilical artery shows an absent end diastolic flow, then in this case we say also that these babies are growth restricted. Or another criteria that can be used is if their growth is less than the 10th centile, then we combine it with the uterine artery PI, which shows which is higher than the 95th centile. Then we can also say that this is a criteria for us to say this baby has fetal growth restriction. Or if the umbilical artery PI is greater than the 95th centile, again, we can say that this baby has fetal growth restriction when they are less than 32 weeks. Whereas for late fetal growth restriction, if the baby is more than 32 weeks and there are no, this criteria is for all those without congenital abnormalities. If the estimated fetal weight at any given time is less than 10 centile, then this baby's fetal has growth restriction. Or if there are at least 2 out of these 3, if the estimated fetal weight is less than the 10th centile, or if the estimated fetal weight or abdominal circumference is crossing centiles, that is, they are losing their trajectory, like I showed you earlier, then in this case also this is a criteria for fetal growth restriction. And then if the cerebral, if the CPR is less than the 5th centile, or the umbilical artery is PI is greater than the 95th centile, there's also another criteria to say that this baby is growth restricted. So the CPR basically means the cerebral placental ratio. CPR, cerebral placental ratio, which means we're looking at the cerebral vascular PI, and then we also look at the placental pulsatility index. and then we find out their ratio. If it becomes less than 5th centile, then in this case also it's a criteria for saying that this baby has fetal growth restriction. So once we have a diagnosis that this baby has fetal growth restriction, then we want to follow up the baby. So the surveillance goals in this case, we want to assess the extent of fetal hypoxia and acidosis at every sitting when we scan the baby. We also want to assess the rate of clinical deterioration. And then we also want to assess whether that baby currently at that particular time when you see them at risk of intrauterine demise or risk of stillbirth. And then we also want to decide on timing of delivery. Should we deliver now? Do we think that we can wait a little bit later on? If we think we need to deliver in the immediate future, either at that particular time we may administer antenatal steroids, or if we think we may need to deliver within the next 2 weeks, again, we may administer antenatal steroids. And then also want to make a plan for appropriate interval to the next review or for the next assessment. That is after we've gone through all these goals. If we think that we can still wait for some time, then we need to determine when the next interval should be. Should it be after 2 weeks? Should it be in a week's time? Should it be in 3 days' time? And the tools that we'll be using, obviously, if the fetal growth, how well is the baby growing, using our biometry assessment, and then the Doppler studies that I mentioned. And then ideally, we should also be doing fetal biophysical profile, and also plus or minus a CTG. The fetal biophysical profile by itself may actually contain a CTG. Currently, in our units, we don't have the CTG, and we haven't been doing much of a biophysical profile. What we've been using for surveillance tools were the biometry and the Doppler studies. Now, in early onset fetal growth restriction, which I said is fetal growth restriction occurring at less than 32 weeks, we have 3 scenarios that we normally come across. The first one, the baby has growth restriction that they are small for gestational age, but the Dopplers at that time are normal. As I said, these babies need to be under surveillance. So we scan them every 2 weeks. And every 2 weeks, what we are doing basically is biometry. Is the baby still growing, following the same trajectory? Is the baby falling off its trajectory? That's 1. 2, then we also do Dopplers. Are the Dopplers still normal or are they abnormal? If they are normal, we scan them again in 2 weeks. The second scenario that we see is that the baby is small and also has abnormal Dopplers. In this particular case, scenario 2 is if they are only the umbilical artery Doppler is abnormal with a high PI, which is greater than the 95th centile, and a low, and also they have a low middle cerebral artery PI less than the 5th centile. So these 2 Dopplers are abnormal. Then now we reduce the number of weeks. We say we scan them weekly. Every week we scan them and see whether the case remains the same as it is or whether it's deteriorating further. Scenario 3, the baby now has absent or reverse end diastolic flow in the umbilical artery Dopplers. Whether this can be together with a low MCA or without, but usually these they follow each other. If there's absent reverse or reverse end diastolic flow, usually the middle cerebral artery PI is also low. In this case, now we scan them every 3 days, and ideally then we should do a CTG for these babies. But in our case, we don't have a CTG. As I said, we've just been scanning the babies every 3 days. So you can see this is where there's no end diastolic flow, absent the end diastolic flow. And in here, it shows that there's now reverse end diastolic flow. And this shows the middle cerebral artery blood flow where the MCA PI has become low. Why? Because the diastolic velocity is now higher. So because of that, it translates to a low pulsatility index for the middle cerebral artery. And also here, there's the ductus venosus, which has been added on, but it shows that there's still a positive A wave. So now in terms of decision to deliver, when do we deliver if the baby is less than 32 weeks and there's fetal growth restriction? The ductus venosus is the one that determines when to deliver. In this case, once it becomes, the A wave becomes absent or becomes reversed, or if the ductus venosus PI is very, very high, in this case, then we need to deliver. Delivery should be done urgently at that particular point in time within 24 hours. As you can see, this is the umbilical artery Dopplers, which I've already mentioned before. And in this case, the A wave is still there, but it's barely there, almost absent. But yet it has become reversed. So this fulfills the criteria for the baby to be delivered within the next 24 hours. So this is very important for us in the fetal medicine unit, is that when we see this baby like this, we need to highlight on our reports that this baby needs to be delivered within the next 24 hours. And ideally follow up also to see if they've been delivered. Because unfortunately, labor wards tend to be very busy and sometimes they don't read these reports timeously. And then we find that the next day the patient is still there, the baby has not been delivered. So it's very important that we not only highlight when the baby should be delivered, and then at the same time also we make a follow-up, see if it has been delivered. Besides that, what we have also been doing the fetal medicine unit is that also we alert the neonatologists of this baby, because this baby will need supportive care because they are less than 10 weeks, they are very preterm, and also they've been suffering from hypoxia and possibly acidosis within the intrauterine in utero. So we get the information of when to deliver from the TRAFO study. That's what we've been following in our unit. And then in terms of late onset fetal growth restriction, we may initially suspect that this baby is going to have fetal growth restriction, obviously, from once we've screened and we see that the uterine artery Dopplers are abnormal. And then we follow them up where we're doing surveillance. If the umbilical artery Doppler is normal, in terms of diagnosing it, we may see that the umbilical artery Dopplers are normal, or sometimes they may be mildly abnormal. In this case, you see them here. They look essentially normal, these umbilical artery Dopplers. But in addition, what you'll see that there's be an abnormal middle to cerebral artery Doppler. So this will fulfill the criteria of late onset fetal growth restriction. So surveillance in this case also has 3 scenarios. This baby, we realize that there's fetal growth restriction, but the Dopplers are normal, or we suspect that there's fetal growth restriction because of our uterine artery Dopplers, which were abnormal. But the rest of the fetal Dopplers and the uteroplacental Dopplers, that is our umbilical artery Doppler, is normal. Then we are going to follow this by doing 2 weekly growth scans and Doppler scans. These are babies above 32 weeks with late onset fetal growth restriction. Where scenario 2, we now have an elevated umbilical artery Doppler PI. So in this case, we reduce the follow-up time to weekly Dopplers with biophysical profile score. And then in scenario 3, the MCA PI has become low. If they are below 37 weeks, then we still follow them every 2 to 3 weeks. Every 2 to 3 times per week with Dopplers with biophysical profile score. And then we do delivery at 37 weeks for these babies. That is, if the uterine artery PI is greater than 95% and the MCA PI is less than 5%, then we are going to deliver at 37 weeks if we can get 37 weeks. But if once they are above 32 weeks, once the umbilical artery Doppler has reversed or absent a diastolic flow, we can also deliver at any time once they are above 32 weeks. So remember what I said, if they are below 32 weeks, we wait for the ductus venosus to make a decision on delivery. But in this case, if the umbilical artery Doppler has absent or reverse end diastolic flow at more than 32 weeks, then we deliver. If the baby remains with abnormal fetal, normal Dopplers, even though our uterine artery Dopplers were abnormal, we will wait for delivery and will deliver between 30 to 39 weeks. So that's the protocol that we've been following in the fetal medicine unit. Thank you for listening. I now give back the